very much to Dr. Batzdorf for covering that important topic. We do have a few minutes for questions, and I already see one there in the back of the room. So I'll tell you what, I'm going to come and collect, so we'll just take, okay, Ansana is going to collect it, so there we go. Dr. Batzdorf, if you'd be so kind just to come down here so we have a microphone. Dr. Batzdorf is the last speaker before our lunch break, so he's his own panel for question and answers. We'll take a few minutes for this, then we're going to break for lunch. We meet back at 1:30. Okay, great. So we've got a number of questions here. Is there a better option than a discogram that doesn't hurt as much as a discogram?
Well, this is...
Oh, I see. Sorry, Dr. Cooper had to get back. So, Dr. Batzdorf, do you want to try to handle that? Or?
Well, it's not really an issue related directly to Syringomyelia. Discography is used by spine surgeons sometimes to define the extent of disc displacement. Sometimes it's even followed by an injection into the disc itself of some local anesthetic in an attempt to define whether or not that is the cause of pain. We used to use discography far more than it is used today. It's not a very, with high-resolution MR scanning, it is, I think, rarely done today, but probably still has place in some situations.
Okay, any other questions for Dr. Batzdorf about Syringomyelia? Okay, well, we're going to break for lunch.
One question.
Yeah.
What you were talking about a while ago, what happens if you can't do, a patient can't handle that?
Why would a patient not be able to handle that?
When they tilted me, I couldn't stay on the table.
You couldn't stay on the table? Well,
you can have a myelogram under anesthesia.
yeah, you can, or so-called conscious sedation. I mean, there are ways of making patients comfortable, sufficiently comfortable, and monitoring their vital signs so that one can proceed with the study.
Do you have a question, yeah?
Yes. You had talked about with spinal deformity. Would scoliosis be considered that, or are you just talking about bone protrusion?
I'm talking about bone protrusion. I mean, scoliosis per se is not, in my experience, associated with obstruction of the subarachnoid space. It takes something more than a curvature, but it takes an actual intrusion into the subarachnoid space, so that the subarachnoid space is at least partly narrowed and impairs the pulsatile flow of spinal fluid.
Okay. We have another question in the back. Sure, if you like.
All right. Can Syringomyelia cause disc degeneration that is irreversible?
To repeat the question, can Syringomyelia cause disc?
My syringes are so large they push my discs out and causing degeneration.
I'm not familiar with Syringomyelia per se causing disc disease. Now, Syringomyelia can cause weakness of the supporting musculature of the spine, and if the supporting soft tissue structures of the spine, including muscle and ligamentous tissue, is weakened, then I could see how that might then result in impairment of the spine to support the body weight and result in disc protrusion. And that's the mechanism which I would think might work to produce that. But syringomyelia per se does not cause, in my experience, disc protrusion. I think it's secondary to weakness of the supporting muscles. There's another question back there.
Ma'am, another question in the back there.
So I had a decompression and I had a syrinx that went from my C-spine down to mid-thoracic. I have more exacerbated symptoms post-surgery of urinary and bowel issues. Can that be from the syrinx in the C-spine, even though it's collapsed and there's no obvious signs of damage? Is it just from like maybe having the syrinx in my cervical spine that I could have the innervation issues?
It's possible. Yeah, it's possible. I mean, one of the issues is that a syrinx causes damage to the surrounding spinal cord tissue, and that damage persists whether the syrinx is adequately deflated or not. And most surgeons would say that the aim of treating the syrinx is to prevent further loss, but sometimes the intervention itself can cause further loss, and sometimes the pre-existing injury to neural tissue can cause that loss. And there's also the fact that how shall I put this, the geometry, the relationships are changed, and if somebody has a syrinx cavity which is suddenly deflated, it puts new tensions on the cord because the cord is collapsed. It changes the geometry, and in some instances even changes the hydrodynamics in the area. So it's conceivable that that might happen.
And lastly, so just to confirm, and I'm sure other people can learn from this, so if you have damage in your cervical spine from it, like if it was present in the C-spine, your nerves in the C-spine can affect your nerves down like where your bladder is and your bowels. Is that correct?
The question is whether a syrinx in the cervical region can affect your bladder and bowel control. Is that what you're...
There's nerves in the cervical spine that control the bowel and the bladder.
Well, the nerves, well, to put it slightly differently, it's not the nerves in the cervical spine, but it is the nerve pathways that go through the spinal cord in the cervical region and innervate nerve cells in the lower cervical, in the lower spinal cord that may be damaged. It's the tracts, the spinal cord tracts that may be damaged by the expanding syrinx cavity that can affect bowel and bladder function if the syrinx is sufficiently large.
Okay, no further questions, and I think it's time to break for lunch. Thank you, everybody, for the great questions, and thank you to our lone panelist, Dr. Batzdorf.